Hello, I'm Roger McIntyre. On behalf of CME Outfitters, I'd like to thank you for participating in Briefcase 3 of the four-part CMEO Briefcase series, Treatment Hurdles in Schizophrenia and Bipolar Disorder, applying real-world cases to overcome challenges in real-world management. This edition of the CMEO Briefcase is titled Missed Opportunities, Tips, Tools, and Techniques to Improve the Detection of Bipolar I Disorder. The goal of this activity is to implement diagnostic criteria and evidence-based tools to improve the detection of bipolar I disorder for early administration of effective care. We are using a unique platform today that is designed not only to provide you with key strategies to improve the detection of bipolar disorder, but also opportunities to reflect and dive deeper into those strategies. As you progress through the briefcase, you will see key points of emphasis along with relevant resources and tools appearing at the bottom of the screen. You may choose to take your own notes by clicking the Add Note button at the bottom right and access those notes on Activity Review page at the conclusion of the briefcase. You can also access a robust resource library, including articles, guidelines, and practice tools by clicking on the book icon also at the bottom right. So let's begin with our patient Brenda, a 26-year-old single Black female who presents with a depressive episode. She's employed in the IT industry, but has been experiencing absenteeism and presenteeism due to depression. Her age of onset of depression is 16 years old. Her current comorbidities are generalized anxiety disorder, and she was diagnosed with ADHD as a child. She has no history of substance abuse or alcohol use disorder. She does smoke cannabis once weekly. Brenda has a family history of drug and alcohol abuse in her father, depression in her sister, and suicide in a paternal uncle. In the past, she has been prescribed antidepressants, but they were ineffective. Hi, Brenda. It's nice to meet you. What brings you in today?
Hi, Dr. McIntyre. It's nice to meet you as well. I think my depression is back.
Why do you say that?
After starting my new job a few months ago, I feel like my boss and colleagues think that my work performance is slow and poor. That really has me down in the dumps. I will admit that sometimes my temper will get the better of me, and I tend to lash out at them. But that has only happened a few times this week. I am a hard worker. I will take on 3 projects all at once. And at first, I am like the Energizer Bunny. I know that I can do this. I will stay up all night if I have to. I am committed to doing a good job, but there always seems to be some problem with my work. I even seek out everyone individually on my team to let them know how committed I am to doing a good job. But I overheard one of them say, "Why does she talk so much?" I'm just trying to do a good job. This really has me in the dumps.
Have you missed any work?
Yes, and I've gotten in trouble about it too. But I tend to make up for it by working overnights most days. I don't need that much sleep. I only need about 2 or 3 hours to function.
Brenda, let's look into that a little deeper. I see from your medical records that you've been prescribed antidepressants in the past. How do those work for you?
I don't know. At first, I thought I felt better. At least I wanted to be better. But after a while, they just didn't help much.
It's interesting that the antidepressants did not work. I'll tell you what, let's look at the overall symptoms that you tend to experience and how they impact your social and work function. Do you mind if I ask you a few questions?
No, if it'll help bring me some relief on this.
And that is exactly what we want to achieve for you, relief of your symptoms. Brenda, thank you for answering these questions for me. Based upon your response, you have bipolar disorder type 1. The symptoms of bipolar disorder are often confused with depression, but the irritability that you often feel with your coworkers, the lack of need for sleep, the talkativeness, these are all signs of bipolar disorder type 1. Let's talk about ways we can treat your symptoms and get you back to feeling yourself again.
Thank you, Dr. McIntyre. I don't know how much longer I can go on like this.
An observation every clinician has made, which would be in accordance with the published literature, is that people who have mental disorders are often affected by many other medical conditions. And it's interesting because when you look at, for example, people with schizophrenia or who have a mood disorder, they have a much higher rate of many different other medical disorders that occur either before or after the onset of their mental disorder. Relevant for so many reasons. It's often we need to focus on not just the psychiatry, but also the medical side. I talk about managing above the neck and below the neck. But it's relevant because this contributes to patient morbidity as well as patient mortality. By now, most would know that people with illnesses like schizophrenia or bipolar disorder have a much shorter lifespan, ranging from 5 to 20 years, often because of an increase in medical conditions like cardiovascular disease. In fact, when you start to break it down in the world of bipolar disorder, what we've learned from many, many lines of research around the world is that our patients who have bipolar 1 disorder and bipolar 2 disorder have much higher rates of medical conditions. Cardiometabolic are especially common, as are other conditions. In fact, any medical condition exceeds in most studies 75 to 90%. So these are not just other conditions, these are conditions that are likely in some cases a consequence of their lifestyle, maybe the medications causing weight gain and metabolic changes in some cases. But really, I think for us is a recognition that we're trying to manage not just the mental disorder, but the comorbid medical disorder. And really, we've got to manage both to give patients the best chance for success. In my experience as a psychiatrist dedicated to helping people with mood disorders, one of the great unmet needs is an accurate and timely diagnosis of bipolar 1 disorder. The majority of people with bipolar disorder begin the illness with depression. Depression is the index presentation. It's also the predominant presentation over time. And so when people go to their care providers, it's often because of depression. That biases the patient, probably biases the care provider towards thinking about a diagnosis other than bipolar, like major depression as an example. Moreover, many people who have bipolar disorder have other co-occurring conditions like panic disorder, ADHD, or drug and alcohol misuse. And these other co-occurring conditions often make it more difficult to really identify in a timely and accurate way, hey, they got bipolar disorder. And this is probably why people wait 5 to 10 years before the diagnosis is made in many cases, despite seeing many, many clinicians. And what I've also noticed is that I often struggle with, I'm not alone on this, in differentiating bipolar 2 disorder from major depression. Bipolar 2 disorder is a closer genetic cousin of major depression, while bipolar 1 disorder is a closer genetic cousin of schizophrenia. And I have found that interface of bipolar 2 disorder to major depression very difficult. One of the persons I'm going to blame for this challenge is Mother Nature. And what I mean by that is, because depression starts the illness, you cannot actually diagnose bipolar 1 disorder if they have mania. And often what happens after 3 or 5 or 7 years later, or maybe later, what we see is the patient starts to have mania. So you have in your records major depression, which was, well, for all sakes and purposes, all you knew, only later for the declaration of bipolar to come. So always be vigilant in a patient who has recurrent episodes, especially when they're having recurrent episodes that are not responding to conventional approaches. Roll up the sleeves, start screening for bipolar. And that conversion rate, it's about 1 to 2% per year. In other words, if I had 100 people in my office today with depression, and I said, come back 10 years from now, about 10 to 20% would have bipolar disorder. So we always have to be vigilant for that. The DSM-5 field trials were conducted to look at the Interobserver Agreement of bipolar disorder. And the observations in the DSM-5 field trials really are in accordance with what you all would expect. Bipolar 1 disorder, mania, has very good Interobserver Agreement. We kind of know what it is. We all agree on it. But bipolar 2 disorder has a much lower Interobserver Agreement, and even major depression even lower. So I always say that the more, if you will, depressed the patient has as their predominant presentation, the more we get the diagnosis wrong. In other words, bipolar 2 disorder has more depression than bipolar 1, but major depression obviously is by definition a depressive condition. So always be thinking about, should I be screening this patient for bipolar disorder? The challenge in diagnosing bipolar disorder comes down to the system of healthcare, the patient, and the provider. The system, we often don't have enough time. We're all time poor, and there's not enough time to really deeply phenotype the patient. In 10 minutes, frankly, it's impossible in many cases to diagnose bipolar disorder. And I know many of us work in atmospheres where that's all you have with the patient. Secondly, we also know that for patients, they often forget information. They come on their own to the appointment. They lack insight. They fail to reveal information. Sometimes they even conceal information. So it often makes it very, very difficult to really get a good history that has the totality of the information. And as clinicians, we have our own biases. Once in psychiatry, someone gives you a diagnosis, that biases every clinician thereafter. So when someone comes to the clinic and they say, "Oh, hi, I've been told I have major depression," that already biases the clinician. And frankly, over the years, what I've often told patients is I say to patients, I've been asked to provide consultation, but I'm purposely not reading the records until after I meet with you first. And the patients usually get that. Sometimes they say, "Well, how come you didn't read my record beforehand?" I say, "Because I want to give you a fresh opinion. And part of the reason why I do it, I don't bias myself. I don't want to know what that previous diagnosis was. I want to give them a fresh canvas, so to speak, approach." So there's many factors that play in. Again, I'm going to blame Mother Nature because bipolar disorder doesn't always fit into nice buckets of mania and depression. We see a lot of patients who have mixed features and so on. That is anxious, agitation, irritability. So just be screening for it. And don't forget that there's ways that we can categorize it. The DSM-5, of course, is the most popular manual in North America, but the ICD is also used in many parts of the world, including North America. In bipolar 1 disorder, you need a mania. One or mania, manic episodes, is what's in the DSM-5. Bipolar 2 disorder, it's alternating hypomania and depression. You need to have that to make that diagnosis. What are some rapid screening tools? Well, there's a few that are out there. The MDQ is probably the best known. 13 items, yes or no. If you check 7 or more positive of the 13 occurring at the same time, and they are disabling, that's a positive screen. Here's my message. A positive MDQ does not diagnose bipolar. A positive MDQ means roll up your sleeves and try and confirm or refute the diagnosis through a good clinical interview. But here's what we do know. The MDQ, if you screen negative, there's a really, really high likelihood you don't have bipolar. That's called negative predictive value. So when you screen positive, you got kind of modest predictive value that you have bipolar. If you screen negative, you get really, really high predictive value that you don't. The CD is used mostly in clinical research. I just put it on here just for your interest. It's a structured clinical interview. There's a few others we use, like the Mini and the SCID. These are used mostly in the research ecosystem. Back to the clinical ecosystem, I want to introduce you to a new screener called the Rapid Mood Screener. We validated this, myself and my colleagues. Simply put, it's briefer than the MDQ, 6 items versus 13. But it has some differences. It doesn't just focus on symptoms like the MDQ. It also includes prior episodes in response to antidepressants, which we call bipolar validators. And I think one of the reasons why the MDQ has maybe more false positives than we like, in other words, people with borderline personality screening positive, I think is in part because there's so much emphasis on symptoms and not enough inclusion of items like age at onset or number of episodes or response to antidepressants. And that really differentiates bipolar from other conditions. And that's captured on the Rapid Mood Screener. Now, with respect to other diagnostic aids, again, the DSM-5 is your guiding light. Remember that the depressive episode criteria for bipolar disorder is no different than major depressive disorder. The criteria list as the same, and you should consult the DSM-5 not only for depression, but also for a manic or hypomanic episode. And there are some differences, as you know, with respect to the duration, especially, and the severity of hypomania, and that's what differentiates it from mania. Now, with respect to other aspects in the area of bipolar disorder, what's the decision-making steps? Well, I think that in any patient who presents with depression, especially when not responding to antidepressants, you got to look for those bipolar validators. What was the age at onset? How many episodes have they had? What's been their response to antidepressants? What's the family history? What's some of the comorbidity they have, like drugs and alcohol? And if we have the time, often the diagnosis begins to kind of fill itself in for us. Do an MDQ. It's a great way to screen. Do the rapid mood screener. It's a great way to screen. And then if they screen positive, try to confirm the diagnosis. Use, for example, DSM-5 criteria or what have you for bipolar 1 and 2. Always be evaluating for suicide risk and safety, of course, and always be concerned about comorbidity, not just psychiatric, but medical comorbidity. And again, I think as part of a collaborative, multidisciplinary approach, try to engage those primary care providers. I think this is really what does patients best. Our primary care providers across the country really are really they carry most of the weight and they help these patients and very skilled at doing so. And I think this is the way I would do it. I also, in fact, would make a case to be aware of some guidelines. For example, the Florida Medicaid guidelines for bipolar disorder, you can download them free. And these guidelines are up to date and they can inform treatment selection across the various stages of managing bipolar disorder. With that, I also would like to say that we like to choose the therapeutic objectives in bipolar, which I call SMART, or refer to as SMART: specific, measurable, achievable, realistic, and in a time-based fashion. And when I sit down with patients to discuss what are the therapeutic objectives, once we get past the I don't knows, which is often what the therapeutic objective is, and we really start to contemplate this, which is very therapeutic, by the way, to go through the process, you will be more likely to achieve your goals if you know what your goals are. And these SMART as an acronym is a very useful, very basic, but very useful way to anchor not just the patient, but also us with respect to achieving those goals. And I would encourage you to consider this framework. Let's summarize with our SMART goals: specific, measurable, attainable, relevant, and timely goals. That is what I hope you will take away from this CMEO briefcase to apply to your practice. Rapidly detect bipolar 1 disorder to immediately implement effective care to reduce disease burden, differentiate bipolar 1 disorder from bipolar 2 disorder and other disease mimickers, use evidence-based screening tools to improve the detection of bipolar 1 disorder. Thank you for joining me today for Briefcase 3 of our 4-part CMEO Briefcase series on treatment hurdles in schizophrenia and bipolar disorder. To view additional briefcases on strategies to communicate long-acting injectables as an effective treatment option for bipolar 1 disorder, as well as applying clinical updates on schizophrenia management and best practices for incorporating treatment planning for schizophrenia, please visit www.cmeoutfitters.com. Thank you again for participating, and thank you for providing the best care for your patients.